Thank you all so much for joining us today. Just a reminder that this session is being recorded and the recording will be posted after the session. So if any of your colleagues weren't able to attend, can absolutely be shared with them, and we'll be sure to share it with you as well. I am going to go ahead and kick it to our presenters today. We are honored to be joined by Taylor Murcio and Ivory Tubbs. And Taylor is going to go ahead and kick us off. If just a quick reminder, if you can make sure you're muted, but feel free in the interactive components of the presentation to unmute yourself and use the chat feature. We will be keeping an eye on it. So without further ado, Taylor, I will kick it over to you.
Thank you. Hello, everybody. I appreciate you all taking time out of your afternoon today. I'm Taylor, and I'll be co-presenting with Ivory. I'm a little bit under the weather today, so if I start coughing and hacking up a lung, Ivory's going to step in and help out, which I really appreciate. So we're here today to talk about stigma reduction and how our attitudes and perceptions can impact substance use and recovery, and so how we can work on reducing stigmatizing language in today's landscape. So our overall goals today, if we want to switch to the next slide, is to describe substance use motivations, how the disease of chemical dependency really develops. We're going to define stigma and identify negative effects, including internal and external stigma. We're going to work on recognizing strategies for identifying and avoiding stigma that's associated with substance misuse. We're going to challenge our negative beliefs about opioid use disorder and some medications for opioid use disorder. And then to finish it up, defining recovery and its elements. So jumping right in with substance use and misuse. One of my questions for everybody, and you're welcome to pop it in the chat or unmute yourself. Why do you think people consume drugs and alcohol, and why can't they just stop? We'll give it a minute. So my question to everybody for the discussion is, why do people consume drugs and alcohol? And why do you think that they just can't stop? So we have someone in the chat, it's a disease. Because they work, it changes their brain. These are great answers. Injuries, absolutely. Generational issues, cultural norms to mask pain, stress relief, codependency, escapism, trauma. These are all phenomenal responses. Thank you, everybody. Absolutely. So there are a few different motivations, right? So one is, if we want to switch to the next slide, to feel good. So, really seeking out that feeling of pleasure and euphoria, relaxation, or even energy to feel better. Some people are talking about stress and generational trauma and things like that. It's a coping mechanism for stress, to self-medicate for anxiety, depression, other co-occurring disorders, and curiosity or social pressure. That's pretty relevant for teens, adolescents, young adults, things like that. I see someone popped in here in the chat, multifactorial causes, ACEs, social determinants of health. Absolutely. We're going to get into that here. So talked about a little bit about motivations, but let's dig a little bit deeper here. So there's many reasons that people misuse substances. Experiencing trauma, especially early in childhood, is a major risk factor for substance misuse. Mental illness is another co-occurring risk factor for substance misuse. And like we were saying, some people may attempt to self-medicate for mental illness using substances. Next slide, please. Someone had popped it in the chat about ACEs. So these are adverse childhood experiences. And I feel that this is becoming a much broader acknowledged term. These are strongly associated with the development of substance use disorders. Many of you are probably familiar with adverse childhood experiences, also known as ACEs. These are negative things that happened during someone in their childhood. This could be neglect, abuse, household challenges, including domestic violence or divorce, having an incarcerated family member, things like that. ACEs can put people at risk for a range of health and social and emotional issues. We find that individuals are 2 to 4 times more likely to report early initiation of substance use with each added ACE score. ACEs account for 56 to about 67% of all serious problems associated with drug use. And those with an ACE score of greater than or equal to 5 are actually 7 to 10 times more likely to report illicit drug use, addiction, and injection drug use compared to those with an ACE score of 0. Someone in the chat also mentioned trauma, and I'm really glad that you did, because impact of trauma is a major risk factor for substance misuse. According to the self-medication hypothesis of substance misuse, people can develop a disorder to manage distress associated with the effects of trauma exposure and traumatic stress symptoms. Substance misuse is a risk factor for trauma, and trauma is a risk factor for substance misuse. So it's this vicious cyclical experience, right? We know that over 70% of adult Americans have experienced one form of a traumatic event. We know that 80% of individuals reported with an opioid use disorder have experienced at least one form of trauma. And over 90% of patients in a public behavioral health program have experienced trauma as well. So, this understanding that this is a cyclical thing, and yeah, some trauma-inducing culture, great comment. Thank you for that. So just kind of setting the stage for substance misuse, how that can happen, contributing factors and things. I'd like to take a minute or a few minutes here to define stigma, just so everyone's on the same page. Did you know that there is no single agreed upon definition of stigma? The origin of the word stigma is Greek, and it refers to a tattoo or a marking that was cut into the skin of criminals, slaves, or traitors. This mark was meant to designate that these people are blemished and to prevent others from associating with them. In more academic terms, stigma can be defined as an attribute that is deeply discrediting, and it's often associated with social rejection and status loss. We have a few components of stigma. So I'm going to break these down a little bit more. So we have labeling. This is when we start noticing and naming differences. Most human differences are ignored. So like the length of your toes, the number of freckles you have, and therefore they're socially irrelevant. Other differences are often selected for greater scrutiny and then social consideration. And these differences are seen as socially significant in our society. Substance use behavior is the difference that we're going to discuss during our session, that's been assigned a specific social significance. Stereotyping is when we start associating named differences with negative traits. A lot of times these associations are automatic. They serve as a way for us as humans to make shorthand decisions without having to engage in the complexity of humanity. These associations are used in decision-making and tend to highlight undesirable or even dangerous traits. Separation is the next one. Excuse me. This is when we start labeling people and considering them separate. That's that us and them. This separation then provides justification for attributing bad characteristics to a group of people. At its most extreme, separation can lead humans to see others as not really human or not deserving of the rights that we assigned to those in our group. Sometimes the labels themselves highlight the separation. So a good example here is that you'll hear people say that a person has cancer versus a person is bipolar. So it starts conflating labels with people's identity. Next, status loss. So this is when we start lowering placement in the social hierarchy. This starts to impact things like whose opinions are sought out and valued, who has influence. And then lastly, we have discrimination, and this is unfair treatment due to those differences. Discrimination occurs in ways that might be overt or subtle. They can be individual or even structural. Wrapping this slide up, just stating that any and all of these components depend on the power difference between those who experience stigma and those who perpetuate it. Anyone can engage in labeling, stereotyping, and separation, but it's the power differential that allows consequences of status loss and discrimination. So, for example, I can sit here in my living room and say that I think that billionaires are selfish and greedy and I don't like them. Cool. I'm labeling, I'm stereotyping, and I'm separating. But my attitude and my statements are unlikely to result in any status loss or discrimination of these billionaires because they're in a greater position of power in society. Let's move on to the next slide. Another helpful way to view stigma is through the lens of fault and control. When we believe that someone is ill through no fault of their own, and or that they have minimal control over their illness, neither the person nor the illness are generally stigmatized. On the other end of the spectrum, if we believe that an illness is within someone's control, and at least partially their own fault, we tend to attach stigma to the person and the illness. Excuse me. So behavioral health conditions, and that includes substance use disorders, are often viewed in this light. This effect is then compounded when someone's using an illegal substance with the added association of potential criminality. You've probably seen communications about opioid use disorder in the media that exemplify that point of fault and control. Oftentimes, people will take pains to point out that the first opioids were taken to treat an injury and a doctor may have overprescribed. This reduces the perception of fault, whereas a person who developed an addiction via illicitly obtained substances may be perceived as more at fault. So that's that spectrum there, where some people with a condition may be considered more at fault than others. We have two types of stigma, right? We have internal stigma, this is self stigma or felt stigma, and external stigma that's enacted and may take the form of discrimination. So we're going to break these two down quickly. Internal stigma. This is self-stigmatization. It's the internalization of negative societal perceptions of one's stigmatized status or group. Self-stigma, this can involve a sense of shame and the expectation of discrimination from others. The expectation of that discrimination can prevent people from seeking help. Perceived stigma is the way that the individual believes that the public perceives them. It's associated with a lower self-esteem, higher depression, anxiety, and poor sleep. So in general, that internal stigma is associated with poor health outcomes. People who experience stigma and must use and often deplete their emotional regulation strategies to cope. And this internal stigma can reinforce maladaptive coping behaviors, right? So, for example, people who experience stigma related to substance use may turn to substance use as a coping mechanism for feeling that way. So, my question to you all, I would be interested to know, have you ever worked with community members that you've noticed experiencing this internal stigma? You know, were individuals feeling shame or fear of judgment? And if so, how did you handle that? Oh, and I see a comment in the chat here about lung cancer opposed to breast cancer, that fault and control. Thank you for that. Community members, not so much, but family members and friends, yes. It makes it difficult when others diagnosed fall under the Department of Health, whereas substance use disorders fall under behavioral health. Yeah, it emphasizes the stigma of substance use disorders. Exactly. Right. So we can move on. Just start thinking about that, you know, the internal stigma and how individuals might be feeling. And then we have external stigma. This is experience stigma. It takes the form of discrimination towards a stigmatized person. This discrimination may be individual. It could be person to person. For example, rejecting a job application or refusing to rent someone an apartment. Individual level discrimination can be tied to a specific behavior, a specific moment in time. Studies have examined the influence of societal external stigma and how this can create social distance. All of this is components of discrimination, but then we have structural discrimination and how that can be a far-reaching and perhaps less visible form of discrimination. This encompasses disadvantages that arise out of that interpersonal individual model, right? So we have things like institutional practices and other policies that can exacerbate disadvantage. So we have an example here of external stigma is against people who have overdosed and been revived by naloxone. These are individual attitudes of discrimination. So you have someone that says that they don't believe individuals who are experiencing overdose deserve to be revived. That's an individual level of external stigma, right? But then this can be exacerbated into institutional practices, such as police departments or first responders refusing to carry naloxone because of these individualized beliefs and stigmatizing thoughts that are then exacerbated into a structural and systemic inequity. So thinking about that leads me to my next question of, have you ever worked with a colleague experiencing or promoting external stigma? And that's a loaded question. You don't necessarily need to answer, but just something to think about. Like, if you're seeing this in your work, think about how it's affecting you, how it may impact a work environment, and how this can impact patients or clients if you're engaging with the public. We have a comment in the chat about refusing gender affirming care based on bad theology. It's a great correlation. Thank you for that. Pardon me, I'm sorry, I'm blowing my nose. So the meat and potatoes of our training today is about stigma and language. So if we want to switch to the next, yes, exactly. So when we talk about potentially stigmatizing language, I like to differentiate between intent and potential impact. Stigma can really be perpetuated through language that we use to talk about substance use disorders. In many cases, the words that we use are inherited. They can be commonly used in settings where we find ourselves. Using these words does not mean that someone has bad intent, but knowing the impact of the potentially stigmatizing language gives us the opportunity to pause and choose a different path. The impact of words that we use is measurable. Word choice, it influences attitudes towards and perceptions of people living with a substance use disorder. There is strong evidence that shows that stigmatizing and negative language used to describe people can have negative impacts on their health. So one strategy that we can use to start identify and avoid stigmatizing language is to perform a language audit. Examine the words that you're using in your speech and in your writing and consider alternatives. And we're going to have a few slides that talk a little bit more about that. The first way to do this is using person-first language. If you call someone a druggie, a junkie, an addict, you're implying that the person is the problem. You're labeling them. You're connecting them to those stereotypes. But if you're saying that someone has a substance use disorder or someone is living with a substance addiction, it implies that the person has a problem, an illness that can be addressed. Next, we can use clear technical language. And so this is a clear meaning that can help both avoid stigma and confusion. So a really good example that I like to use here is talking about the results of a urine drug screen. Some people might use the words dirty or clean to describe the outcome of a urine drug screen. That's conflating drug use status with a person's cleanliness. The more accurate and less value-laden ways to describe test results is just like you would any other test result, positive or negative, the same way you would with any other medical test result. Common examples, we have she abuses pills. So abuse is a negative and harmful behavior. It's often associated with immorality, right? He's an addict. Using that in that term, it demonizes the person, it depersonalizes the patient or client. So this next slide about language replacement is one of my favorites. Here we have some common terminology on the left. These words are incredibly common. They may be used by your patients or clients themselves. We have addict, abuser, junkie, substance abuse, denial, relapse prevention, clean or sober, resistant to treatment. Okay, if people choose to describe themselves as clean and sober, that's their choice. Sometimes taking on the label of addict is important to some people, particularly in mutual aid group settings. They see this label as a constant reminder of their recovery journey. In general, though, as professionals, we can make the choice to use less value-laden terminology when we're describing someone living with a substance use disorder. So the alternative terminology section on the right-hand side are suggestions that are intended to switch the language around substance use disorder to align more closely with the language that we would use to describe other chronic illnesses. So instead of relapse, we have recurrence or return to use. If we describe a patient as in denial or resistant to treatment, we're evoking a provider-centered worldview. So we can say choosing not to. That starts to reinforce that patient-centered language, that patient-centered perspective that really values the autonomy of our client. Do we have any thoughts or questions about this slide? Usually this evokes a lot of thoughts. Okay.
Actually, this is Joy.
Hey, Joy.
So when where does the term disordered use come in? Substance use disorder, or because one part of I'm in prevention, and so one of the things I'm always thinking about is, people use for a variety of reasons, but when it causes harm, it's disordered use, right?
Mm-hmm.
So where does that come in the frame of stigma?
That's a great question. So I think using disorder is acceptable. We have that here in our alternative terminology list, right? I think that by defining something as a substance use disorder, it's a clinical term, right? It's using that clear terminology that doesn't conflate abuse or negative or immoral thoughts, right, to a disease that someone is living with. A disorder is something that is a medical diagnosis, something that's able to be treated and addressed with medication, therapy, things like that. That was a great question. Thank you. And I see in the chat here, hearing more about denial versus ambivalence, not heard that before. Yeah, so by thinking about, when a patient is resistant to treatment or they're denying treatment, things like that, that's operating from this provider worldview, right? So we have, as healthcare professionals, as individuals working in the treatment or prevention fields, things like that, we understand the importance of engaging in treatment, importance of staying adherent to medications, things like that. But that's from the provider perspective. The patient-centered perspective is understanding that someone is an autonomous human being, that they have their own ability to make decisions. And so by describing a patient as potentially ambivalent or understanding their choices, that they're choosing not to engage with treatment, we're reinforcing that patient-centered perspective and really valuing the individual's autonomy and decision-making, even though it might go against what providers think and want for the person. When someone who may identify as an addict, should we reference them as such in that specific situation? Like pronouns, that's a great question. So again, like I was saying, for some individuals, taking on that title of addict is important. And I think just like we would have the conversation about pronouns with someone, what is their preferred space, there's the opportunity there to have an open dialogue about why individuals are choosing to utilize that terminology, why they're taking on that label, and maybe unpacking, maybe there's some of that self-stigma, that internalized stigma that's just perpetuated in the language they use. And as a care professional, you have that opportunity to open up a dialogue with your patient or client about there's an alternative terminology, what is your preference and why do you want to take on this label? For some, it's really important. For others, it's because that's the only language that's ever been used. So like I was saying, a lot of this language is inherited. It's stuff that's been around for a long time. And it's on us now to start moving forward and unlearning this language and choosing alternative terminology that's less stigmatizing. If we want to move forward, I have a quick language exercise. I think we have some time for this. We don't have to do all of them, but the idea is that there's going to be a few sentences up here. And so I'd love an opportunity to identify stigmatizing language in the sentence, explain why it might be considered stigmatizing, and then how could we reword it to replace stigmatizing language. So we have Paul. Paul is a substance abuser. What about the language in that sentence is stigmatizing? And how could we reword it to replace the stigmatizing language? Abuser, exactly. Abuser is that negative word. It had harmful behavior, has immoral association. I see a suggestion here. Paul suffers from substance use disorder. Beautiful. Well done. Someone who uses substances, absolutely. So we have, let's just go to the last one, and then we'll move forward from this exercise. Sally keeps providing dirty urine for her drug screens. What about that sentence regarding Sally's dirty urine for her drug screens is stigmatizing? Dirty, exactly. It's conflating drug use status with cleanliness. How can we reword that to replace the stigmatizing language? Sally has consistently tested positive for drugs. Sally has positive urine screens. Exactly. Sally's urine drug screens have come back positive. Really well done, guys. Thank you so much for that participation. So another strategy, jumping away from the language that we use in our verbal communication, is the nonverbal communication. Noting and paying attention to your tone, your posture, your face and body movements. Poor nonverbal communication can reinforce stigma, and it can be associated with worse patient outcome. Conversely, if you're making appropriate eye contact, if you have encouraging vocal tones and open body posture, that can really have a positive impact on individuals' outcomes. So an example that I like to use here is pregnant persons that are living with a substance use disorder. Oftentimes, there is a lot of internal stigma and then the external stigma from the healthcare professionals that are engaging with pregnant persons living with a substance use disorder. There is an agency in Arizona that when someone comes to, oh, it's hailing now, so sorry if that's noise in the background. When a pregnant individual comes to the treatment center, the first thing that these individuals say is, congratulations on your pregnancy. We're really excited for you. And by promoting that positivity, that encouraging tone, by keeping an openness to understanding that individuals live with a disease and are still going to move forward with life and their choices, is going to be so positive. The next part of communication that I'd really like to touch on are visual portrayals. And so this might not come up as frequently in your work, but it's worth mentioning. So these are visual portrayals of people with a substance use disorder. We've all seen media coverage of people who have overdosed. Sometimes police departments will share clear photos of these people with the media. And so even without verbal commentary, the sharing of these images sends a message that the privacy of people who have overdosed is not a priority. So that's the other. This is that stigmatizing space. They're not deserving as the same rights as us. This type of nonverbal communication can have a tremendous negative impact and then can compound both internal and external stigma. So I encourage you all to be on the lookout for negative visual portrayals of people with substance use disorder, either in media or advertising, especially if you're developing literature like patient brochures, things like that. An image portrays a moment in time. Sometimes those images are staged, but they're always an incomplete depiction of the subject. So nonverbal communication, whether it's body language, visual portrayals, things like that, can be used to perpetuate stigma.
This is again Joy. I work at Rosecrans Jackson Centers here in Sioux City. And one of the challenges we have is they have a lot of posters around of life's waiting for you, but all those life's waiting for you are people with perfect teeth, perfect skin. They all look beautiful. And so you still have to be beautiful to be portrayed as a successful life. And that's a frustration for those of us in our field, as we know, is, if you have bad teeth, if you have bad skin, if you have needle marks on you, you're not going to see yourself in those images of hope. And that's really challenging, I think.
No, that's a great point, Joy. Thank you for that. I feel that oftentimes the most impactful images and portrayals are those living in recovery, individuals who have achieved a sense of a space of personal wellness and health, and have sort of regained their autonomy back, right? Those tend to be the most impactful visual portrayals and stories to be shared. That being said, not sharing images of a mother who is OD'd in the grocery store, right, with the small child next to her, that was circulating around, or individuals that have overdosed and are sitting in their car, like that police departments often share. It's being mindful of images like that. Oftentimes images can be triggering. So if you're showing needles or things like that in brochures, while you're trying to be educational, it can be triggering and conversely negative, right? So, but thank you for that. That's an excellent point, that maybe moving forward with treatment or recovery and hope, maybe don't use stock images of people with perfect hair and perfect teeth and things like that. Great thoughts. Thank you. Does anyone else have thoughts, questions, comments, concerns before we move on to medications for opioid use disorder and stigma? All right. If you do, please feel free to drop in the chat or unmute. So MOUD and stigma, I just wanted to touch on this. So MOUD, MAT, MOUD, they're one and the same. Medications for opioid disorder are FDA-approved medications. It's in combination with counseling and behavioral therapies that have been proven to be effective in the treatment of opioid use disorder and can help some people sustain recovery. So the FDA-approved medications, we have 3 of them. We have buprenorphine, methadone, and naltrexone. These medications, they relieve the withdrawal symptoms, physiological cravings that can cause chemical imbalances in the body. They're evidence-based treatment options, and they don't substitute one drug for another. There are goals of MOUD. The first is to stabilize abnormal brain activity. The second is to reduce cravings and strengthen coping capacity. The third is to allow patients to focus on behavioral therapies. The next is increasing periods of abstinence and self-efficacy. And lastly, we're looking to improve clinical outcomes for clients and reduce the impact on families and loved ones. So there's a handful of stigmatizing thoughts about medications for opioid use disorder. So the first misconception that I hear pretty often is that MOUD replaces one addiction with another. I have a feeling that a majority of people on this call today have heard this phrase before. It's a common one. Addiction is defined by a repeated use of a drug despite negative effects on mental health, physical health, and interpersonal relationships. Taking a medication that has been prescribed to you by your doctor to treat a chronic illness doesn't meet that definition. Next slide, please. Medications for opioid use disorder help to break the cycle of drug use, which is the euphoria, a crash, and cravings to use again. Methadone and buprenorphine, as we know, have gradual mechanisms of action. They stabilize brain chemistry without producing euphoria or leading to a crash. All 3 medications help reduce cravings and the euphoric effects of opioids. So I think that kind of dispels this misconception that it replaces one addiction with another. It's not. It's taking a medication for a chronic illness. The second misconception is that detox is a form of treatment, or detox is better than MAT, or in lieu of MAT. There's no evidence that detox programs are effective at treating opioid use disorder. Medically supervised withdrawal can be a first step in addiction treatment. Next slide, please. But without treatment after detoxification, patients are likely to start using again. Detoxification without treatment, like a methadone, like a buprenorphine, like a naltrexone, they can increase the chances of overdose death because it's lowered someone's tolerance. Next misconception is that MOUD is only intended for short-term treatment. There's no one-size-fits-all approach to treatment length. Addiction Understanding this and viewing this as a chronic disease will help individuals understand that this is going to require long-term care. Next slide, please. In general, the longer that patients stay in treatment, the better their outcomes. Research does not support unassisted abstinence as an effective treatment for opioid use disorder. So, and the last misconception that I'd like to touch on today is that MOUD is not effective because it doesn't immediately cure or end drug addiction. Medications for opioid use disorder are not intended to cure opioid use disorder or addiction. Addiction is a chronic illness that impacts individuals for their entire lifetime. Next slide, please. MOUD and these medications, they manage the physiological aspects of a substance use disorder, of an addiction. This allows clients and patients to focus on identifying the underlying causes of substance use and work towards recovery. And then the very last misconception, MOUD is inferior to complete unassisted abstinence. I feel like a broken record here, but scientific evidence shows that addiction is a chronic disease. It's caused by repeated exposure to a drug coupled with genetic or environmental risk factors. This process leads to a physical change in your brain's opioid receptors, right? Next slide, please. Addiction can be treated and managed with medication, counseling, much like other medical conditions, much like other chronic illnesses. MOUD has been proven to be more effective than treatment approaches that focus on complete unassisted abstinence. So that was my little soapbox there about some of the common misconceptions that are associated with medications for opioid use disorder. Before we move on to the last section of the training, I wanted to open it up to hear if anyone has thoughts or comments or questions regarding that section. I know I skipped through that rather quickly.
Hi, this is Savannah from Price, Utah. I
Thank you,
loved
Savannah.
that. So in our ER, and we're a rural hospital, we just opened the Bridge program, which is someone who struggles from an opioid use disorder can walk in and be initiated on Suboxone. And I think, in our community, we're so small and rural that a lot of people said, you're just changing one for another. And I would, in my response to them after hearing it 5 or 6 times is, yeah, that's exactly what we're doing. Like we want them to change from heroin and fentanyl to Suboxone. Like that's exactly what we are doing. And this is why, and to try and educate them on the benefits of MOUD, and to see like it switch in their brain and they finally see like the importance of MOUD treatment is such a huge moment.
Absolutely. Savannah, thank you for sharing. I know that I've really been enjoying working with you all in this contract. And I think, yeah, just driving home that, this is a medication prescribed by a doctor to treat a chronic illness. It's not a repeated use of a drug that is creating negative effects on mental health, physical health, or interpersonal relationships. That these medications are helping to break that cycle of drug use, that they help stabilize a person's brain chemistry, things like that. I think that's
Good afternoon,
great.
This is Ashley Harmel from SLTC's Adult Education Program. I was calling back to answer any questions that you might have about adult ed. I do want to let you know that we will not be registering students until July.
Jessica, do you have the opportunity to mute?
Classes. And
Yeah.
you're welcome to call
Thank
me
you.
back anytime if there's anything.
Yes. So Savannah, thank you again for that comment. And I see a few other comments in here about how medications for opioid use disorder have saved lives. They restore a person to community, things like that. And so if anyone ever needs talking points or resources to help show that these are medications for a chronic illness and not illicit substances that are engaging with substance use disorder, please feel free to reach out. The last section of this training is just talking about recovery and how we define it. So how do you all define recovery? Welcome to unmute, pop some thoughts in the chat, whatever you feel comfortable with. while we're waiting for that, if we want to go to the next slide, I see developing a healthy lifestyle. This is my definition of recovery. It's a process of change through which individuals improve their health and wellness. They live a self-directed life and they strive to reach their full potential. I see a handful dropping in the chat here. A better quality of life, developing a healthy lifestyle, learning to live and enjoy life without the use of drugs, have a life worth living. Yes, it's individualized. It's a process of change. Recovery is a lifestyle, not an event. Oh, I love that one. Recovery is a lifestyle. Thanks, Ivory. Remembering what a life was and can be without the substance. I love all of these. Absolutely. You know, maybe your patients, your clients have a different definition, but there's some common elements of recoveries that I'd like to highlight. If we go to the next slide. We can go to the next slide. So common elements of recovery, you know, we have treating addiction as that chronic disease that can enter a stage of remission, right? Understanding that complete abstinence may not be a realistic goal for everybody. Viewing recovery as a lifelong journey that may include several cycles of recurrence or remission is something to be mindful of. And lastly, addressing whole person wellness beyond simple substance use behaviors or patterns is so important for those of us working in this field. I do want to touch on recurrence of use. So this is a return to substance use is a very common part of the recovery process. How this return is framed can really affect patients or clients. Framing a return to use as a failure is obviously demoralizing, and it can reinforce that internalized stigma. This does not equate to a moral failing or of the patient, or if the patient that being a lost cause. Remember that no one treatment, remember there's no one size fits all. No one treatment will work for all patients with a substance use disorder. This is the opportunity here to replace terms like relapse with more descriptive language like return to substance use or recurrence of use. You know, being aware of your patient's concerns and modifying treatment plans is going to be really important, just like treating any other chronic illness. If someone is unable to maintain recovery, whatever that looks like for them, with their current treatment plan, they may need a referral to more intensive treatment or additional recovery supports. So just to wrap it up, and then we can open it up for any questions, comments, or concerns. Key points, takeaway today. Stigma, it can be internal or external. Either way, it has a measurable negative impact on health and health outcomes. We have strong evidence to address a lot of the stigma-laden misconceptions about medications for opioid use disorder. We have identified some strategies for recognizing and avoiding stigma, including performing a language audit on ourselves, right? And increasing awareness of nonverbal communication, whether that's physical or visual. And lastly, just viewing recovery as a process of pursuing health and wellness, rather than a destination defined solely by abstinence. That can really help reduce stigma surrounding recurrence of use and recovery supports. So I think we're down to about 10 minutes or so, right?
We have about 15 minutes left.
Oh, beautiful. Cruise to do that. So would love to open it up. Questions, concerns. We have tons of references available for all of the information that we presented today as well, if anyone has thoughts or would like them.
I'd love your list of resources. This is Joy. One of the biggest challenges that I have, again, I'm in prevention, but is there's a double standard around substance use. Iowa is a huge drinking state. We are number 2 in the nation on heavy drinking and binge drinking, but that's okay, right? And try and touch that and people get really ticked off. We also have medical marijuana, which essentially is state-funded THC dealers, right? And that's okay too, because it brings in revenue. So it's a frustration for us is that there's a hierarchy of substance use, some of which are okay because they're so embedded in culture, and others are just elevating the otherness of people. And I have It always comes down to me somehow to revenue. In my faith tradition, the love of money is the root of many evils. And I think when states are making money off of something, they're less likely to try and manage it.
And Joy, this is Ivory. I want to continue on that vein. I think one of the things that we deal with in this field are accepted addictions: sugar, alcohol, caffeine, nicotine, right? It's the onus is upon us in this field who see people on a daily basis or talk to people on a daily basis to really just give people that point of introspection, to take a minute, take a stop, hold on a second. I know with myself, it happened just today. I can't tell you the last time I had a donut, but I started eating this donut and I didn't want any more, but I kept shoving it in my face, right? And that's just sugar. I mean, and it's making that correlation between, you know, someone who's using an illicit substance and being able to paint that picture for people who have the stigmatizing language, or people who use the stigmatizing language, or who stigmatize people with SUD. I think that is one of the places where we can kind of pivot this thing a little bit and give them a different perspective, because a lot of people look at it as it's cut and dry, it's black and white. Those, you know, these are illicit drugs and these are not. Well, caffeine is a highly addictive stimulant, very well researched, but we shove it down our throats every day. So I just want to add that.
It's a great money-making venture too, coffee shop.
Absolutely.
Anyone else? Questions or concerns?
Taylor, we have a question in the chat. It's a little far up, but someone said, I'm joining a bit late. Have people with lived experience been asked about what language they prefer?
Yeah, it's a great question. And I think we touched on that a little bit earlier when we were going over the you know, sort of antiquated language and alternative terminology section. And we align that with the importance of asking about people's pronouns, preferred pronouns, and things like that. I think opening that dialogue with your patient or your client about what language they want to be using regarding their personal journey, where they're at in their recovery, where they're at in their engagement and treatment, things like that is very important. By asking individuals what their preferences are, really puts that patient-centered perspective, that autonomy into their hands. Oftentimes, individuals living with a substance use disorder have become so stigmatized in the healthcare setting that for a provider, a person in that position of power, asking them what their preference is, how they want to be referred, where they're at, things like that, is just really going to put the onus in the power back into the person's hands and really help with that autonomy. I don't know if that answered the question.
I'll piggyback that real quick.
Yeah.
Taylor, just from some of the patients that I've seen over the years, some of them don't have the self-esteem to tell you what they prefer. And it's just that simple. So I think when you offer them an option of giving them other terms and what language to use, some of them don't know. Some may take you up on your offer, but some just don't know. And again, that's our job to kind of help fix that.
Exactly. That might be the opportunity to say, you know, if you don't know what you prefer to be referred to as or things like that, I'm going to go ahead and choose individual living with a substance use disorder, because this is a chronic illness. This is not who you are. It's something that you're living with. It's something that we're going to focus on together. And I think that really aligns well with this change, this, you know, paradigm shift that we need to be engaging in to help reduce stigma surrounding substance use disorder and treatment. Looks like we have a comment here. Sometimes think that the difference between language that's preferred in the professional space versus language that the public at large will understand to engage them in conversation, relapse versus return to use. Absolutely. And that's on us as the healthcare professionals, as the individuals working in these systems, to start making that change, to start talking about it. You know, if you're engaging, if you're, you know, in a setting with colleagues that are using stigmatizing language, you know, you have the opportunity to say, hey, just learned about this alternative terminology, or how would you feel about maybe using this terminology? You know, if you see something, say something, kind of thing. Anyone else? I no need to say, yeah. Looks like there's a survey that Jessica's going to pop in the chat. Jessica, I'm gonna turn it over to you. Please take it away.
Great. Thank you so much, Taylor, for this information. Folks, we really appreciate you joining us. We are going to be putting a survey in the chat. Looks like Margie just put it there. This survey helps us with, we do have to do reporting to SAMHSA on our events, and we really just want to hear from you on what you thought of today's event. And we will do the same survey for future events, with the caveat, we are working on building this with being a very new grant. So please do be patient about the clicks. It will take less than 5 minutes, but we hope to have it a little more streamlined as we move forward. So we very much appreciate you. We will stay on. So if there's anyone who has a specific question they'd like to ask Taylor or Ivory, please do feel free. We will be here through 2:30 Mountain Standard Time. So feel free to stay on, chime in whenever, and we'll keep monitoring the chat. And again, thank you so much for your time today.